Ladies and gentlemen, I think it's time to get started so that we can all get out at a reasonable time. I know there's some great conversations being had, some networking, but maybe we can take that up at lunchtime. So ladies and gentlemen, I'd like to start the next session, which is dealing with the interventional means of dealing with neuroendocrine tumors. Our first speaker is Dr. David Liu. He is currently in Vancouver. Actually, there's been a change in the program, so we'll go with the flow. Dr. Reid, who I know as a colleague, he's frequently in my office, and I think in terms of we demonstrate that there's a good communication and a working relationship between different parts of imaging. So Dr. Reid.
Thank you, ladies and gentlemen. This little talk was requested by one of the patients. For the past 24 years, I've actually been treating bony metastatic disease with radioisotopes. First of all, with P32. Secondarily, our hospital is one of the main ones that did development work with strontium-89, and latterly we did a lot of research with samarium-153 EDTMP. Now, one of the things that we have, and I'm just going to run fast, I'm not going to repeat a lot of stuff because a lot of people have shown images of patients with neuroendocrine tumours with bone metastasis here, and one of the things that we have is that many of the patients are, especially non-secretors, you end up getting them referred and they've got bone pain, but they're not secretors. And many times you find out they've got bony metastatic lesions because they're being operated for other pathologies. Now, the interesting thing is now that with somatostatin analog therapy, a lot of patients are surviving a lot longer in better condition. So now we're beginning to see other issues come to the foremost, one of which is bone pain because of the metastatic lesions. And it actually was quite interesting. We didn't see this very often 10, 15 years ago. And now we're finding out, and the latest figures I got when I was browsing through, it was thought to be less than 5% of people had bone mets with neuroendocrine tumours. It actually turns out it's closer to 15% of the patients who've got metastatic disease that when they present have actually got bony metastatic disease. And 70% approximately of these people can have bone pain. The question is, what do you do about it? Now, the interesting problem that we have is that those sites who have the availability of indium-111 nucleotide therapy, lutetium, yttrium-90, are actually have options compared to other sites which don't have that availability. And again, it's the investigations are, again, you have to do all the scans, the bone scan, the CT, the MRI, to assess the patient fully. And what you see on these scans and the patient's clinical condition will actually tell you where to go. But again, the biggest problem is if you don't have the availability of the radioisotope therapies, because our experience is that most of the radioisotope therapies, if a patient has bone pain with bone metastasis, and other systemic disease. Most of our experience is that if you treat them with the indium-111, MIBG, we don't have any access to the other newer agents, but we find that within 2 weeks, 2 to 3 weeks after treatment, most of these people, their bone pain is gone. And we've had people go up to 2 years, 2.5 years between treatments, a course of treatments before pain has come back. So in actual fact, the serendipitous factor is that when you're treating people with the radioisotope therapy, you actually treat their bone pain. The biggest problem that you get is if you ain't got the radioisotopes to treat them, you're left with a problem. What to do about the bone pain? Well, if the bone scan is positive, you can actually treat them with one of the strontium-89 or samarium-153. And in about 75% of the time, you will get a response and you will get rid of the bone pain. There are two issues. One, if you've got an impending fracture or a collapse of a vertebra, no matter what you do, neither of the radioisotopes that you have available to treat the strontium-89 and the samarium-153, they will not get rid of pain related to a fracture. So, if a patient has pain and they have an impending fracture, that fracture has got to be surgically stabilized. The other issue is that you may have to do spot radiotherapy to that area if there's an impending fracture. Now, when you don't have other therapies available, the other option is actual radiotherapy. Now, and again, radiotherapy, the response from radiotherapy by beam, conventional radiotherapy, the response rate is something between about 80%, which is very similar to the radioisotopes. Again, it's radiation you're giving. One of the problems that you have is if somebody, a radiotherapist, looks at the study and sees multiple bone lesions, they tend to be, oh well, we'll cover that area as well. They'll do a wide field. However, one of the problems that you have is, if you do that, you can impact on the bone marrow volume. You can reduce the bone marrow volume, and if your blood counts go down, that can technically impede other therapies. For example, if the patient's going to get chemotherapy, whatever. So the thought of what you're going to do to treat these is it has to be done in a very logical fashion. And again, it comes back to the multidisciplinary group that we've all been talking about. The patient has to be seen, you have to look at all the options, and then decide what the best treatment is. Again, if you haven't got the peptide therapies, then you're left with the conventional radiation, chemotherapy, pain control with narcotics, which are not good for the patient because they ruin the quality of life. And the other thing that's really interesting is bisphosphonates. It's a load. The bisphosphonates, 10 years ago, they weren't used very much. And now what's happened is you get patients who, if you put them on the bisphosphonates, you do get some pain control and stabilization of the disease, particularly if there's lytic disease. We had patients in the past who we didn't see any uptake in a bone scan, had lytic disease. Now, once you've been treated with the bisphosphonate compounds, that lytic lesion stabilizes and you actually can see a positive bone scan, and as a result, you then can consider treating them with samarium or strontium-89. So that's a factor now that in the old days, there were a proportion of people with lytic disease, you couldn't do it. Now, just to continue here a little bit. And as I said, you've got the two groups of patients, people who can get the peptides, the people who ain't got the peptides. Now, as I indicated, the people with the peptides, you have multiple options. That's the issue. You have multiple options. With widespread bone disease, you have the problem with bone marrow suppression. And that is where you can do very well at getting rid of the bone pain, but you may not be able to proceed with the full therapies because of marrow suppression. And we have had this happen where we've had patients, widespread metastatic disease from their carcinoid or their insulinomas and all these other tumours, and we give them one treatment, you get rid of the bone pain, but they've got such widespread marrow disease, you can't treat them again. So it's very difficult. It's a two-edged sword. And again, if the patient has had significant chemotherapy before, significant radiation before, you run into problems, because if the radiation has been to an area that the pain comes back in the portal that was treated before, you may have lost the expression of the receptor, and you may have bone pain, you may have a lesion expanding, but you've got no peptide uptake that you could actually even treat the patient and hope to treat the patient. Are you on time? Okay. Hey, I'm getting a dose of my own medicine. But there's 2 points here. With strontium-89, you cannot give chemotherapy for at least 8, 10, 12 weeks after till the bone marrow recovers. With samarium, you can actually go, although they say 8 weeks, you can actually go with samarium earlier. So people think that, well, you can't use them because they'll they'll decrease your bone marrow, or they'll delay chemotherapy. In actual fact, judiciously used and carefully looked at, we've had treated patients with samarium with the counts have actually recovered within 4 weeks. You can go ahead with chemotherapy. With strontium-89, you have to wait at least 8 to 10 weeks, and that, using strontium is one of the problems if you're going to use chemotherapy for disease elsewhere. You want to get rid of the bone pain, but with strontium, you have that problem of getting back into the chemotherapy side of it, and the same with the peptides. So you have to really, really carefully do this, but if you use it with the peptides and the patient has bone pain, 70 to 80% of the time you can get a lasting pain effect relief. If you don't have the peptides, then you are back to the conventional treatments, which may or may not work. And we have patients now, there's one patient that we have who's had 11 treatments in about 9 years for has bone lesions, and every time the bone pain comes back, you treat them, and you get a very long response rate. And this was a little quick talk just to bring people up to that degree. Thank you.